Good morning. It's my pleasure to welcome everyone to the 2018 Thomas Covey Jr. Visiting Professorship. A couple points. Dr. Covey is up there. Dr. Covey is one of four four surgeons I personally know who were born in Beckley. He's sitting with one of them. And there are two others that I know. Pretty remarkable. Dr. Marsh and I were looking, and it says the Beckley is about 15,000 people now. I don't know whether that's it's been that size for a long period of time, but there's something in the water down there that produces outstanding surgeons, and I think that's quite remarkable. Dr. Covey went on to Harvard Medical School, trained at the University of Michigan, and took his first academic position at Washington University in St. Louis. He was recruited back here to WVU in 1984 and was a very revered surgeon in the state, and certainly locally, and was a leader not only in the growth and the development of the department, but of Ruby Memorial Hospital as well. We had a wonderful dinner last night. It's great to hear Dr. Covey has some great stories from his training and early time here on faculty. So I just want to say welcome and thank you for the support of this lectureship and all your commitment to education of not only our residents but our medical students. Dr. Covey continues to teach anatomy for medical students. I think he told me last night he's done for the year. But hopefully we can get Dr. Covey involved with our skills lab, our cadaver lab, and we can find ways to help him with the students. So, Dr. Covey, thank you. It's good to see you. It's my pleasure to introduce Dr. Lynn Yip. She is Associate Professor of Surgery at the University of Pittsburgh Medical Center. She began her medical education at the University of Chicago. Began her residency at the University of Florida, did a research fellowship at MD Anderson, and finished her training at Northwestern. She then arrived in Pittsburgh to do a surgical oncology fellowship. She loved it so much she decided to do another fellowship in endocrine surgery. Loved that so much she decided to stay on as faculty. She is currently Associate Professor and Program Director for the Surgical Oncology Fellowship. She's a member of many national organizations, the Society of Surgical Oncology, American Association for Endocrine Surgeons, American Thyroid Association, American College of Surgeons. She's co-authored over 75 peer-reviewed journals. She's a well-funded researcher, and it's our pleasure to welcome you to WVU. Enjoyed dinner with you last night. And so I'd like a warm welcome for Dr. Yip.
Well, thank you very much. I really do appreciate the invitation to come. It was a pleasure to meet everybody last night, and especially a pleasure to meet Dr. Covey and his wonderful wife, Hope. Thank you very much for the support of this lectureship. I really do sincerely appreciate the opportunity. So I'm going to talk to you today a little bit about thyroid nodules and just a little plug about endocrine surgery. The reason why I love endocrine surgery so much is because I'm going to not talk so much about how we do thyroidectomy. That's just one very small part of what we do. But really, what I love about it is that we think a lot about why we're doing it, when should we do it, and what should we be doing. So my only disclosure is, this is a very sort of defensive disclosure. I am going to talk a little bit about molecular markers today, and ThyroSeq is something that's been developed at UPMC. It's been marketed to CBL pathology, which is commercially available. I myself receive absolutely no financial direct or indirect compensation related to this marketing. So today we're going to talk a little bit about the epidemiology of nodules and thyroid cancer. We'll outline the diagnostic algorithm for thyroid nodules and discuss some of the current challenges involved in managing thyroid nodules, and also review some of the contemporary treatment options in the management of thyroid cancer patients. So we see a lot of thyroid nodules. I'm sure you see a lot as well. I'd say any given week, about 50% of my clinic is filled with people who have incidentally discovered thyroid nodules, and they just need some kind of evaluation for those nodules. They are detected in up to 65% of people at autopsy, and on routine ultrasound, they can be seen up to a third of those patients. They're much more frequent in elderly patients, in women, in areas that are iodine deficient, and also in patients who have a history of head and neck radiation previously. Interestingly, thyroid cancer is one of the few cancers that is rising in incidence. And so this year's SEER data, they actually estimated nearly 57,000 new cases of thyroid cancer. 1 in 83 people will be diagnosed during their lifetime, and women are threefold more likely than men. You can see down here that thyroid is the 5th most common cancer in women. And this was last year's number, which was an estimated number of cases of 42,000. So it's definitely rising. And there are geographic hotspots. And so this is a map of the United States. This is the incidence per 100,000 cases. The red is the highest. You can see there are our area over here is definitely a little bit of a hotspot, and there's some areas over here on the West Coast too. And what's interesting about this distribution is that it really doesn't reflect access to care. So I don't think that screening and care healthcare access is necessarily the whole reason why we're seeing these hotspots. These are some numbers for West Virginia. This is where we are right now, and you can see right here, there's a little bit of a spike right here extending into Ohio and Pennsylvania, and then we're right here, and so we're definitely part of that hotspot too. So overall, when we find a thyroid nodule, the goal is to make sure there's no cancer in that nodule. So overall, the risk of cancer in the nodule is about 5%, which is relatively low. The risk is higher in pediatric patients, and if you have a personal history of some kind of cancer, the risk is up to 50%. There are some risk factors, people who have had prior head and neck radiation. So we used to give radiation routinely to babies for tonsillar thymic-adenoid enlargement. We know now that that's not such a good idea because people would develop cancer down the road. It actually used to be routine treatment for benign dermatologic conditions, and we still actually see some patients who have had that in the past. And we still, of course, give radiation for people with childhood malignancies. Even neuroblastomas can sometimes, they try to spare the thyroid, but it can be very difficult because the kids are so small. If you have a family history of cancer in a first-degree relative, it can increase your risk of cancer. And there are a number of thyroid cancer predisposition syndromes, which are seen here, that have a risk of thyroid cancer as well. The only thing I'm going to say about this slide is that there is an entity called familial non-medullary thyroid cancer, which has a very strict definition of multiple family members across multiple generations who have thyroid cancer. And there's a lot of interest in looking at what those genetic predispositions are, and we really still don't quite know. So there are a number of different types of thyroid cancer, and they almost all arise from the follicular cells, which are the sort of workhorse of the thyroid. They are the cells that produce and store thyroid hormone. And the most common kind of cancer that we see from this, of course, is papillary thyroid cancer, which is about 80 to 85% of the cancers that we see. It has an excellent survival with over 95% overall. Fortunately, the cancers with very poor prognosis are also very rare. Medullary thyroid cancer is a very popular research cancer. People like to look at it, although it's very infrequent in general. But it arises from the parafollicular or C cells, and these are really neuroendocrine tumors of the thyroid. They can be very difficult to treat, and I'm really not going to talk much about those at all today. So one of the reasons why we think that there's an increase in thyroid cancer in particular is that potentially this could be due to screening and aggressive evaluation of all nodules. And this is old data, about 10 years ago. And what they did was they looked at SEER data, and they found that the rise in thyroid cancer that you can see here appeared to be mostly papillary cancers, and it appeared to be mostly in these smaller cancers. And interestingly, this was also reflected in some recent studies out of Korea. So South Korea is a very interesting story. So back in 1999, they instituted an aggressive population-level cancer screening program. And so all people would get aggressive screenings of colon cancers, melanoma, et cetera, et cetera. And as part of that, they also, for an extra $30 or $40, you could also get your thyroid ultrasounded. And so a lot of people did that. And so you can see here that with that kind of aggressive screening, the more number of adults that had that screening, the higher the incidence of cancer was. And what's really interesting is this graph over here, that you can see there's definitely a very sharp rise in thyroid cancer incidence, but this thyroid cancer mortality line is completely flat. And so despite this aggressive screening and despite this aggressive treatment, they would actually take out thyroids for very tiny little cancers. There was no change in the thyroid cancer mortality across the population. And so I think they've subsequently stopped, at least thyroid cancer screening in Korea, but it certainly is a lesson for us as well. However, if you look at some of that SEER data a little bit differently, there's actually not just these small, tiny cancers that we're seeing. So there's an increase in thyroid cancer among patients with big tumors, greater than 4 centimeters, with distant metastases across all race and ethnic groups, suggesting that it's not just, again, healthcare access, but potentially something else going on. And it also suggests that there may be some other environmental, dietary, and/or genetic causes that could be causing this increase. And this was just recent data, and so for years and years, people said, "Oh, well, the increase in incidence is definitely it's worrisome, but we're not really seeing any increase in mortality," which is actually not true. So this group, Dr. Sosa down in Duke, they looked at that SEER data again and just changed that y-axis a little bit more, and they were able to demonstrate that there is an increase in thyroid cancer-related mortality of 1.1% per year over the past few decades. And so there's, we're not just potentially overdiagnosing, but on the other side of the spectrum, we're probably not doing a great job of treating people with advanced thyroid cancers either. And so at the time of nodule evaluation, it is important to figure out if it's cancer. The best, and the ideal thing is to figure out the best initial management of that central compartment. And so ideally, we would like to not take out benign nodules and to also better risk assess if a nodule is cancer, what should we do with that nodule? And so there are a number of clinical factors, and for all you residents that are getting ready for your boards, the first answer is, of course, you want to take a good history and physical. So things that increase our concern for cancer are rapid nodule growth, if there's a family history of thyroid cancer, or a personal history of some inherited cancer predisposition syndrome. If you have had a childhood history of ionizing radiation, then this increases our worry about cancer. And there are a number of physical exam findings that are worrisome as well. Fixed nodules, cervical lymphadenopathy, and if patients are hoarse, then we worry about the nerve becoming compromised. But ultimately, everybody gets a thyroid ultrasound, and thyroid ultrasound is really the gold standard test for people with thyroid nodules. It can determine if there's a nodule that's corresponding to what we're feeling on physical exam, and it gives us a lot of information about the nodule itself. How big is it? Is it solid? Is it cystic? Does it have any suspicious imaging features? And it ultimately helps facilitate biopsy. So this is a nodule that is completely benign. This is what we call spongiform, and it is thankfully named for exactly how it looks. It just looks like a sponge. This is nearly 100% specific for something that's benign. On the other hand, there are other nodules that we are, these are solid nodules, so this is something with a nice halo. This is potentially cystic and nice and smooth, also not that worrisome. And nodules that are flat or oval are less worrisome as well. On the other hand, nodules that lack the halo have this sort of irregular spiculated border and are taller than wide, as well as have microcalcifications, are more worrisome for cancer. And in fact, if you see a nodule that's suspicious, then you have an inkling that perhaps this patient may have more aggressive disease. And this is just one of many studies that have been published looking at over 500 patients with papillary thyroid cancer. And if they went back and looked at the ultrasound, the nodules that had more suspicious features actually had a higher risk of recurrence over long-term follow-up. So those ultrasound features and size ultimately drive our decision for whether or not these nodules need to biopsy. And this is from the most recent 2015 ATA guidelines. And you can see that even if it's suspicious, we generally won't biopsy these nodules until they're a little bit bigger, where it clinically makes more sense to do so. On the other hand, nodules that are less worrisome can potentially not be biopsied at all, just be observed depending on the patient and the associated symptoms. But all nodules, we ultimately rely on the biopsies to decide what to do next. And since 2008, all thyroid nodule biopsies are classified into one of these 6 categories. You can see that these are the risks of cancer right here that have subsequently been validated in a meta-analysis that was published a few years ago. And for the most part, if nodules are benign, then we don't worry too much about them. Or if they're cancer, then we know that what to do. We should take those nodules out. And the problem is these 3 categories in the middle, what we call the indeterminate cytology categories, and these have a very wide-ranging risk of cancer from anywhere from 5 to 15% all the way to up to 6 to 75%. But the majority of these will still be benign. The solution for years and years and years is to take these out to make sure there's no cancer. However, we're doing an awful lot of surgeries for nodules that are ultimately going to be benign. And so the types of surgeries that are potential options for people with either cancer or even benign or even indeterminate nodules are to either do a lobectomy, which is to take out part of the thyroid. This includes the isthmus, which is basically a postage stamp size tissue on top of the trachea. The advantage of it is that about 20 to 30% of patients that's actually, should say 20 to 30% of patients actually need to be on thyroid medication, so the majority of the patients should not require medication. There's no risk of permanent hypoparathyroidism or bilateral recurrent laryngeal nerve injury. The downside is that if it turns out to be a little bit more of an aggressive cancer, then patients may need a second operation to do a completion thyroidectomy. The other alternative is to do an initial total thyroidectomy. And the benefit of this is it's a one-stage surgery, but there is a risk of permanent hypoparathyroidism and bilateral recurrent laryngeal nerve injury, which is devastating. And of course, all patients will need to be on long-term levothyroxine. And the surgical risks vary widely in the literature, but in general, the things that we worry about are hematoma that require a reoperation. Unilateral recurrent laryngeal nerve injury that's permanent should be about 1 to 2%. Bilateral recurrent laryngeal nerve injury is not very well reported, the incidence, but generally runs about 1 in 1,000. Hypocalcemia is usually usually temporary, can be seen in up to 20 to 30% of patients after surgery, but long-term should be about 1 to 10%. And of course, we talked about the needing to be on levothyroxine. And as we discussed, although surgery is fun and we like to do it, it has risks. And with indeterminate biopsies in particular, we're doing a lot of surgeries, about 500,000 biopsies per year. About 25% of these are going to be indeterminate, and the majority of these are not going to be cancer. So perhaps we shouldn't be operating on all these patients. So that's where molecular markers comes into play. And so molecular testing was initially developed as a diagnostic adjunct for this specific category, these indeterminate biopsies. And there's a lot of different types of commercially available tests. Afirma is a gene expression classifier that's RNA-based. There's another test called Rosetta, which is, again, mRNA classifier, a 24-gene classifier. There's another test called Thyroidectomy and Thyroid, which is actually out of Pittsburgh. And this is a 7-gene panel with 10 microRNAs. And then the fourth test is the one that I had mentioned before, which is Thyroidectomy test, which was developed at University of Pittsburgh, which is currently a multi-gene next-gen sequencing panel. I'm not going to bore you with the details of this test, but of these 4 tests, but the idea is that if you have a biopsy and it comes back indeterminate, then you would get this molecular testing, and it ultimately answers whether or not you need to have surgery at all. And so what we're really interested in is the negative predictive value. So this will tell you whether or not the nodule is going to be benign. Now, negative predictive value and positive predictive values are derived from test sensitivity and specificity, which are inherent properties of the test itself. So those are not really that changeable, but it is also very heavily dependent on cancer prevalence. And so you can't really take a negative predictive value and positive predictive value from a paper and apply that to your own personal practice. You have to look at what your own personal cancer incidence is within sort of the institution. But just to give you an idea, these are the landmark papers from all 4 of the tests that I was mentioning. And you can see here that the negative predictive values range anywhere from 91 to 100%. So this is actually very good. The current NCCN guidelines recommend that if you can prove that the nodule has a risk of cancer that's less than 5%, then it would be okay to survey that nodule as opposed to taking that patient to surgery. On the other hand, the positive predictive value is a measurement of how likely this nodule is going to be malignant. And you can see here that this ranges very, very widely. So the Afirma test has a PPV that ranges anywhere from 30 to 40%, depending on what kind of a study you look at. And so for these patients, all you can say is that if it's negative, it's likely going to be benign. If it's positive, you have a risk of cancer that is still less than 50%, but probably some kind of surgery is necessary. On the other hand, some of these other tests could provide a little bit more information about the genetic background of the nodule that allows a little bit more fine-tuning of what kind of surgery should be offered to patients. You can see here, these are all the costs associated with the different tests. There have been a number of cost efficacy studies that have shown that most of these are relatively cost efficacious. But ultimately, what kind of test you decide to order should consider the clinical variables, right? So if you're going to take out that nodule no matter what, it's a big nodule, the patient is bothered by it, or else you're worried about it based on ultrasound features, and it doesn't really make any sense to order any kind of molecular testing. Pediatric patients likely have a different mutation profile. We think that those cancers tend to be more likely driven by rearrangements as opposed to mutations. So some of these mutation tests may not be quite as accurate for pediatric patients. And furthermore, they have a higher pretest probability of 30% for those nodules. And then Hürthle cell neoplasms are a completely different beast. So these have a different molecular signature, we think, than regular papillary or follicular thyroid cancers. And so these tests may be a little bit less accurate for Hürthle cell neoplasms as well. This is an area of active interest, and there are a lot of studies coming out that have looked at this in a little bit more detail. But ultimately, if you decide to do this molecular testing, then if it's negative, then it's great. Then you can potentially avoid doing surgery. And this actually, depending on the test, can avoid surgery for up to 60% of patients. So I think it's definitely worthwhile to consider and think about. But if it's positive, then the question becomes, well, what kind of surgery? Remember, we talked about either doing a low versus a total. What's the best kind of surgery for these patients? And so coming back to our initial goals of nodule evaluation, so we think that we can pick out those nodules that may not need surgery based on biopsy and based on cytology as well as molecular testing. But can we better risk assess those nodules that could be cancer and ultimately drive what kind of surgery we're offering patients the first time around? And back in 2009, which is not that long ago, but 2009 was the last set of ATA guidelines, it was really easy. So if you thought it was cancer and it was less than a centimeter, you would offer a patient a lobectomy. If it was over a centimeter and you thought it was cancer, then you would just offer an upfront total. But in the meantime, there's been a lot of new data coming out suggesting that even for thyroid cancers, potentially we may not need to take those patients to surgery. So maybe we could just do active surveillance. I'm going to show you that data for that in a second. Lobectomy may be adequate treatment for a lot of cancers instead of total thyroidectomy. And then there's been a lot of controversy about how aggressive we need to be with lymphadenectomy or thoroughly cleaning out the central compartment to clean out all microscopic lymph node metastases. And the idea is that the correct surgery for thyroid cancer would be ideal because the first operation is the safest. There's a lot of data supporting that. And we really want to try to be as precise as we can the first time around. And so this is the data for the active surveillance. And so this was actually kind of novel data. So about 10, 20 years ago, the surgeons in Japan said, well, why are we taking out all these little cancers? It seems like they are pretty small, they don't really do much, and they're not very aggressive. Can we potentially just leave them alone and watch them? And so they started to do that. They offered patients with small, less than 1 centimeter cancers that were carefully selected, and they just observed them as opposed to taking them to surgery. And you can see they published their series over several years. So the first 5-year report, you can see that disease-specific mortality was the same, whether or not you operated versus just watched them. The incidence of developing local regional recurrence over time was identical. Distant metastases, also the same thing, identical. About 7% of patients at the time had nodules that increased in size and eventually needed to go to surgery. And then in follow-up, 10 years later, you can see those numbers are nearly exactly the same, but now the nodules, there's a certain subset of patients that will have nodules that will grow, about 20%, and those patients will eventually need to have surgery. And so this, a lot of patients, 1,400 patients had this surveillance, and you can see based on this, active surveillance is now recommended as a potential option for some patients with small cancers. There's a lot of caveats to this. So number one, these studies were all done in Japan, so we don't know if the cancers in Japan are identical to the cancers here. There's some suggestion that similar to Korea, the Japanese have these high incidence of very small cancers that tend to be indolent, so maybe that's not translatable to what we see here. And so there are a lot of ongoing prospective clinical trials. We have one up in Pittsburgh, there's one at Memorial Sloan Kettering, looking at sort of which cancers make sense for active surveillance. It doesn't make sense for some patients who potentially have a long way to go, so this requires a commitment from the patient. It is 6 months of follow-up every 6 month follow-up for 2 years, and then every year after that. And then for some patients, they didn't really look at quality of life. So is it too anxiety-inducing to have a cancer in place? For some patients, they just don't want to deal with that, and they just want it out and not have to worry about it. And so I think there's a lot of other factors that come into play, but it definitely is an option and another potential solution for some of these patients. And so now in the 2015 ATA guideline, active observation is an option for patients with small cancers. And our well, I'll come back to that. The other thing that we talked about is whether or not to do a lobectomy versus a total thyroidectomy the first time around. And so back in 2009, I showed you that algorithm that if it was big, you were supposed to just take the whole thing out. But in the interim, there have been some recent studies that have suggested that potentially lobectomy provides equivalent outcomes to total thyroidectomy. So this was a study of a lot of patients out of the NCDB, and on unadjusted calculation of overall survival, you can see that total thyroidectomy did indeed provide better disease outcomes, although it's statistically significant, although you may argue that 1.5% may not be clinically significant, but regardless, they got a p-value. However, if you went back and adjusted that data for comorbidities, for tumor characteristics, that advantage for total thyroidectomy went away. And so this is ultimately part of why lobectomy is now also a potential consideration for people who have cancers that are 1 to 4 centimeters. In addition, we don't give radioactive iodine to everybody anymore. There are a lot more conservative indications for radioactive iodine ablation. We reserve it for high-risk cancers and some selected intermediate-risk cancers. And so if you're not giving radioactive iodine, there's really no need to take out the other thyroid, the other lobe. In addition, our ultrasound is so sensitive now that we think that we do a pretty good job of picking up clinically significant cancers based on ultrasound imaging prior to surgery. And so the idea that you're leaving cancer behind is really sort of a moot point at this point. So and then the third thing that we often talk about is how aggressive do we need to be in that central compartment. So at the time of surgery, we usually will take out the thyroid within the central compartment, which is bounded by the carotid arteries, the hyoid superiorly, and down to the innominate inferior. But the question is, how aggressive do we need to be about cleaning out those lymph nodes? So there's definitely clear-cut indications for being aggressive if there's clinically evident or imaging evident disease. In patients with medullary thyroid cancer, the board answer is always that you have to do a comprehensive central compartment lymph node dissection at the time of your initial operation. And if there's evidence of lateral node metastases, the incidence of having central compartment is nearly 100%. But there's an increased risk of hypoparathyroidism when we do that. Some series report up to 50 to 60% of temporary. And there's also an increased risk of recurrent laryngeal nerve injury if you do this as well. And so there's been a lot of debate about whether or not we should be doing prophylactic nodal dissection, meaning that even if there's no obvious evidence of nodal disease, should we be cleaning out the central compartment anyway to make sure we don't miss anything. And in the meta-analysis, this did result in a 40% reduction in the risk of recurrence, but we had to treat 31 patients in order to prevent 1 recurrence by that calculation. And so there's been a lot of back and forth in terms of whether or not this makes sense. So on the one hand, people say, well, if you can better stage patients by really accurately looking at the lymph nodes, this allows for better risk stratification. But for a lot of endocrinologists, this doesn't really change what they're going to do. It's difficult to evaluate these lymph nodes by ultrasound, but a lot of things that we're taking out are really micrometastases, which are clinically insignificant anyway. And there's really no data for improved survival by being this aggressive. And so it ultimately comes down to sort of balancing the morbidity and perhaps being more selective about those patients who need to have this aggressive treatment. And so the ATA guidelines now are very confusing. So if you have a small cancer, you can potentially not operate. If you have a larger cancer, you could do a lobe, you could do a total, you can do the central compartment if you want, or you don't have to if you don't want to. And then, of course, if you have larger cancers, then it's pretty clear-cut that you should be a bit more aggressive. But this middle category really is a bit of a head-scratcher. And the problem is that what kind of surgery the patient ultimately needs depends a lot on histologic factors, which are only known postoperatively, right? So how in the world are we going to figure this stuff out preoperatively? And so these are the ATA categories: low risk for recurrence, 1 to 2%; intermediate risk, and high risk for recurrence, up to 20 to 30%. And again, you can see here we do not usually give radioactive iodine for these low risk cancers, but we generally will give it for these high risk cancers. And all of the defining features are related to aggressive histology. These are not things that you can see on the biopsy. Whether there's any extrathyroidal extension, again, not visible necessarily on the ultrasound, and having lymph nodes that are involved. And so if you look even further, they parse it out even further in the ATA guidelines. And so this is very complicated. You don't need to know all this information, but molecular testing, nodal extension, I mean, these are not things that we can see in a preoperative evaluation. So how in the world are we supposed to figure this out? And so the kind of things that we have preoperatively, we have ultrasound, we have cytology category, and we also have some patient demographics. But even with this information, there have been some studies that have shown that we still do a very poor job of risk of stratifying patients prior to surgery. So in this study, 40% of patients had high-risk features that were seen that were not known pre-op. And in this study, if all these patients would have had initial lobectomy, about 40% would have needed completion. We actually also did our study up in Pittsburgh, looking at 447 patients from our institution, and we actually did our study a little bit differently by just looking at patients who had a pre-op biopsy that was either positive or suspicious. So we knew that these patients had cancer going into surgery. And right off the bat, about 20% of those patients will have high-risk cancer, and that treatment will be relatively straightforward. But the majority, about 80% of patients, will have intermediate risk cancers. And if we would have done a lobectomy by the ATA guidelines for all of these patients, we would have misclassified. So about 50% of patients would have actually been intermediate risk, and about half of them would have been low risk. It is a little bit helpful to know the type of biopsy they had prior to surgery. So if you have a positive biopsy, there's a slightly higher risk of having more aggressive disease. But ultimately, if you would follow those ATA guidelines, we're doing a lot of completion thyroidectomies for patients that may not necessarily, that hopefully we could do something to make that better prior to surgery. And so looking at what we have available prior to surgery, we looked at these factors: age, gender, size, FNA cytology category, and then we also looked at tumor genotype. And so over the past years, we've definitely had a much better understanding of the type of molecular mechanisms that are involved in thyroid cancer. And so the majority of these molecular changes involve the MAP activating mutations involving the MAPK pathway and the PI3K AKT pathways that are seen here. I'm sure a lot of these mutations look familiar to you: RAS, PTEN, mTOR, and all of these ultimately drive carcinogenesis. And so about 95% of all thyroid cancers are either papillary or follicular. And about 70% of these cancers carry one of these 4 genetic changes: BRAF, RAS. There's actually 3 isoforms of RAS, REP-PTC rearrangements, or PAX8-PP-ARG gamma rearrangements. And so back in 2007, Yuri Nikiforov, who's a scientist slash pathologist, came to our institution, and he developed the 7-gene panel using those genetic changes. And so at the time, we were doing conventional sequencing, which is, any of you, I don't know if you still do this in the lab, but it's very ponderous. You look at the gel and you read it out manually, and it's sort of a pain. But we would do this routinely for all of our indeterminate thyroid nodules, hoping to get a better, a little bit more diagnostic specificity. So biopsy is very sensitive at picking up thyroid cancer. So if you have it, it's likely to find it, but it really lacks specificity, meaning that it picks up a lot of people who don't have cancer, and we talked a little bit about that earlier when we were talking about those FNA categories. And we've previously shown that if we use this 7-gene panel, we can actually improve that diagnostic specificity. By the ATA guidelines in 2009, it actually helps us direct the extent of initial thyroidectomy. It subsequently reduces healthcare costs, which is all very good news. However, until we had the long-term follow-up, we really were not clear about whether or not these molecular markers provided any prognostic information. And so we went back and looked at this recently. Our institution, 1,500 thyroid cancers were were evaluated, and all these patients had genotyping, so we know the mutation for all 1,500 of these cancers. And we found that tumor size and the rate of multifocality was not associated with mutation, but you can see here that they actually stratified into two separate groups. So these cancers with BRAF V600E or RET-PTC rearrangements had more aggressive disease, extrathyroidal extension, central compartment lymph node metastases. Up to 35% of people with RET-PTC mutations had lateral lymph node metastases as well, and up to 8% of patients with RET-PTC mutations also had synchronous distant metastases, usually lung metastases. On the other hand, cancers that were RAS, PAX-A, PPAR gamma, or BRAF K601E tended to be much more indolent. They did not have these aggressive features. And when we looked at recurrence, so a mean follow-up of only 3 years, we had 9% recurrence. We actually found that by Kaplan-Meier, they stratified very nicely into two separate cohorts. These patients had nearly no incidence of recurrence, whereas these patients with BRAF V600E or RET-PTC had about a 60 to 70% incidence of recurrence. And so that actually provides us with information that we can identify preoperatively. So based on the biopsy, we can actually send this for genetic testing and get this mutation testing prior to doing the operation. And so we looked at that same information in that study that I just showed you, and we found that all these variables, so older age, being a woman actually was more associated with having more aggressive disease, larger size, having a positive biopsy, and having BRAF or RET-PTC detected preoperatively was associated with having more aggressive disease. And so this allows us to hopefully better stratify who may benefit from initial total thyroidectomy, whereas if you don't have these factors, then potentially those people can go for lobectomy. But since 2007, the status of cancer genomics has sort of marched on, and now we know a lot more about thyroid cancer. This is from the TCGA, which did whole genome analysis of nearly 500 papillary thyroid cancers, and they found a number of other single nucleotide variants, driver mutations, genetic changes in known suppressor genes. About 15% of patients had gene fusions, and then there were a number of these copy number alterations that were found in follicular variant papillaries as well as Hürthle cell cancers, that category of cancers that I told you before that were a little bit difficult to characterize beforehand. And so what's really remarkable is that based on their study, they only had less than 2% of cancers did not have any driver alteration. And this is really amazing. I mean, how many other cancers do you know can we fully characterize those cancers in all but 2% of cancers? So for example, breast cancer, we still don't know what causes breast cancer. And so this is really very exciting and very novel for the field. And in addition, we now no longer have to rely on ponderous conventional sequencing, but we now have next generation sequencing. This is all automated. You can do massive parallel sequencing. It's very sensitive and super cheap. And currently all genetic testing nowadays is done by next generation sequencing. And so our panel has subsequently evolved. So we had 7 genes back in 2007. We had 15 gene panel back in 2013, a 60 gene panel in 2016, and we've just released our most recent panel, which is even more than that. And I'll show you a little bit more about that. And so as a result, this is the 100% of all thyroid cancers. This was our initial 70% with the 7 genes. We've been able to gradually sort of chisel away at this yellow slice right here, and hopefully one day we'll be able to get rid of this yellow slice altogether. And so that panel, in addition to having a lot of diagnostic power, also provides a lot of prognostic information too. So all these genes, BRAF, PIK3CA, TERT, P53, CTNNB1, and ALK, all these are potential markers of aggressive cancers. And so if we find these cancers up front, we know that we have to be a little bit more potentially aggressive at the time of surgery. RAS is a very tricky marker. It actually can be found in the full spectrum. So we see RAS in benign nodules, we see RAS in indolent cancers, and we also see RAS in some poorly differentiated and anaplastic cancers as well. So RAS is a little bit trickier. And then we actually have a couple markers here, GNAS and TSHR receptor, that are really markers of benign nodules. So this is all very helpful information. So just a word about BRAF. So BRAF V600E is a marker that was one of the earlier markers that was found. It comprises about 40 to 50% of thyroid cancers, and it initially, we thought that BRAF was associated with more aggressive cancers. However, there are a lot of indolent cancers that tend to be BRAF positive as well. And in fact, in Korea and Japan, the majority of those cancers are BRAF positive. And we think it's related to iodine, not toxicity, but iodine replete populations. But as part of a multi-institutional international consortium, we've actually provided some of our patient information to Mingzhao Cheng, who is at Johns Hopkins, and he's had a number of these large studies. You can see here about 2,000 patients with BRAF positive cancers, and BRAF V600E was associated with mortality. So this dotted blue dot is V600E negative, and then this straight line is BRAF V600E positive cancers. However, if you actually look a little bit further into the data, this mortality risk was not independent of histologic features. So if you took into account lymph node metastases, extracellular extension, distant metastases, we lost this association. So it's helpful potentially preoperatively when you don't know anything else, but it may not be so helpful after surgery. But what's really interesting about BRAF is this recent data that we published, that there's an age-dependent association with BRAF and mortality. So these are the patients with BRAF V600E positive cancers, and you can see that as you get older, the adjusted risk of dying actually remains a straight line. So that risk continues to increase as you get older if you have a BRAF positive cancer. However, if you have a wild type BRAF, that risk plateaus. So it doesn't matter if you're older, it doesn't make any difference at all, which is very fascinating. So I think there's a lot of information that we still need to know. This is just an observation of epidemiologic data, and ultimately we'll have to dig a little bit further into the molecular to see what is it about these cancers that is different. The other prognostic marker that there's been a lot of excitement about is TERT. So TERT promoter is telomerase reverse transcriptase promoter. And there have been a number of studies that have shown that TERT in thyroid cancer is associated with increased mortality. This is a meta-analysis comprising a lot of the initial studies. You can see that if you have TERT and in combination with BRAF, this reduces your chance of survival. BRAF and TERT also increases, this is recurrence, also is associated with mortality. And among the high-risk cancers, it is an independent marker of poor prognosis as well. And what's really exciting is this. So TERT, we see aggressive cancers in about 5 to 10% of patients. And so these numbers actually coincide with those 5 to 10% of patients. So this actually potentially is a very powerful marker of poor prognosis as well. And so I promised that I would tell you a little bit about the more recent Thyroid-seq. So the older versions included just single nucleotide variations or mutations. It also included a lot of gene fusions, but our latest version also includes a lot of copy number alterations, gene expression markers, a lot broader panel of insertions and deletions that were previously not able to be detected. And so our next step is to look for some of these other genetic changes in these subsets. So comparing BRAF positive, aggressive versus non-aggressive, and just trying to see if there's some other molecular profile that we can define that will help us better figure out what's going to be aggressive prior to surgery so that we can better refine that surgical management. And so this is that 2015 algorithm, and our goal is to use molecular testing to help us better decide who needs a lobectomy versus a total. And actually, this is a prospective trial that we are running right now. We have been running this since about a year now, and we have about 30 patients on the trial. And so the idea is that we do the biopsy, we send it from molecular, and depending on the molecular profile, we'll decide if they do a lobectomy versus a total thyroidectomy. And we anticipate that this trial should be closing in the next couple of years, and I'm excited about that data, and hopefully that'll bring some interesting information as well. So in summary, the goal of thyroid nodule evaluation is to exclude thyroid cancer, ultimately. We use neck ultrasound biopsies, and these are the diagnostic tests of choice for euthyroid or hypothyroid patient. We think that molecular testing can help guide management of indeterminate cytology and ultimately can help predict biologic behavior and response to treatment, and we're actively doing future studies to help define this further. So in summary, the goal of thyroid nodule evaluation is to exclude thyroid cancer, ultimately. We use neck ultrasound biopsies, and these are the diagnostic tests of choice for euthyroid or hypothyroid patient. We think that molecular testing can help guide management of indeterminate cytology and ultimately can help predict biologic behavior and response to treatment, and we're actively doing future studies to help define this further. So there are a lot of questions, though. I mean, I think we've gone quite far over the last decade or so, but there's a lot that we still need to do. So from a diagnostic standpoint, if we don't operate on these nodules with indeterminate cytology, what is a long-term outcome? So they're not cancerous now, but are they going to be cancerous in 10, 15, 20 years? We don't know. And so we need that long-term follow-up data for these nodules that are being surveyed. And then if we do this correct for surgery for cancers, does it really improve the outcomes? And I'm not just talking about cancer outcomes, but I'm talking about quality of life and patient-centered outcomes. And so that's another huge area. If you do a lobectomy for a cancer, is that really the right thing for the patient? And so as part of our trial, we're actually looking at some of those outcomes as well. They're all doing quality of life questionnaires to get a better sense for that as well. From a prognostic standpoint, is that molecular signature truly independent of pathology or ultrasound? Are there other preoperative variables that we can look at a little bit more closely to help us decide what is the best surgery? And then from a therapeutic standpoint, if we don't operate on the low-risk cancers, is that also the right answer? Are those cancers, can we predict those 20% of nodules that are going to grow or become more aggressive? And we're hoping that molecular will help us figure that out as well. In addition, as I alluded to from the beginning, we're not doing a great job of patients with aggressive or distant disease who are radioactive iodine refractory. So these are the patients that die. There are a lot of new treatments coming through with tyrosine kinase inhibitors, ALK inhibitors, small molecule inhibitors, and we think that these have differential response depending on the tumor profile, but we need to define that a little bit more and potentially use some of that information to develop better treatments for patients. And so we're not done yet, for sure. So in conclusion, molecular signature is an emerging component of pre- and post-operative risk stratification, and we think that it's really helping to refine our current management strategies for thyroid nodule and thyroid cancer patients. So we have a very busy and comprehensive multidisciplinary thyroid center, and a lot of what we do clinically and research-wise relies on these two people. This is Dr. Sally Carty on your right. She is my partner. And Dr. Yuri Nikiforov, who I spoke about, he's the pathologist who has developed a lot of this testing. And then all these people are active members and have participated in a lot of the research that I've done as well. And I'm happy to take any questions. Yes.
So, first question, do you do this testing on every patient who comes in and their FNA shows papillary cancer?
So we offer it if there's no other reason for a total thyroidectomy. So patients who have bilateral nodules, who have any aggressive ultrasound features, or who are already on levothyroxine, we will go ahead and offer, I'll say to them, you can do a lobe or a total. These are the pluses and minuses. If they're still a little bit on the fence, then I say, well, we can also do molecular testing to help us sort that out. Right now, molecular testing is not being paid for by insurance for nodules that are positive because they were developed and validated for indeterminate nodules. So we can get them for those three categories that are indeterminate, but we can't get it for the positives. So we're doing that currently as part of the trial. That trial is completely philanthropically funded. There are a couple of thyroid cancer patients who were interested in our research and gave us money to do that trial. So,
Do you do a lobe on a 3-centimeter papillary today?
Depends on the patient. So if it truly looks encapsulated, I would, by all means, absolutely offer that. Yeah. Yes.
Thank you. This is great. In the context of the new classification of NIFP, how do the molecular markers impact or confuse the situation where we may have these totally encapsulated lesions that may look like cancers on cytology that will then come back as these indolent lesions? Is there, any way or potential, any future to using genetics to predict where, so we could be less aggressive in those patients and potentially offer them lobes for the NIFP?
Yeah, so NIFP I don't know if you all know what NIFP is, but NIFP is a new nomenclature designation. So we used to have this whole category of cancers called encapsulated follicular variant papillary thyroid cancers. And these cancers, we knew, people who were in the thyroid cancer world knew that these were not truly cancers. They were very indolent and tended to have a very low incidence of metastases or recurrence. But they had this cancer label, which freaked out patients, it freaked out endocrinologists. It was not a good thing. And so those have since been reclassified as non-invasive follicular variant thyroid neoplasms with papillary features. I don't even know. I think I'm saying the whole thing, but we call it NIPS-P. And so the point of the nomenclature reclassification was to take away the word cancer so that patients wouldn't necessarily need to be anxious about that nodule. And so the thing about NIPS-P is that, number one, it has to meet very strict histologic criteria. So there's a whole list of what kind of lesions truly meet this NIPS-P criteria. And the second thing about it is that the only way that you're going to be able to figure out if this is a NIPS-P or a cancer is by taking it out and having pathology look at it. Currently, there are no molecular, cytologic, or ultrasound characteristics that can 100% differentiate NIPS-P from just a general encapsulated follicular variant papillary. And so from a surgical standpoint, from a diagnostic standpoint, these still need to be resected for pathology to look at. And downstream, depending on the pathologist and depending on the endocrinologist, hopefully these would be treated by lobectomy alone. So to answer your question, we are looking at some molecular characteristics of NIPS-P, things like RAS. We think these PAX8 PPAR gamma, EIF1AX, all these mutation changes may be related to NIPS-P, but they're not 100%. And so ultimately, it still needs histology to define.
In your clinical trial, are you looking, what outcomes are you looking at? Are you looking at survival outcomes, or is it the type of cancer is like low, intermediate, or high risk cancer? Because the survival outcomes would take a long time.
You're absolutely right, and I deliberately didn't talk about it because, so that is a very good question. So that is the sort of the problem with thyroid cancer trials, is that in general, the reason why we don't have a lot of trials is because the outcome, survival, nobody dies from thyroid cancer, and when they die, decades from now. And so it's nearly impossible to run a trial based on survival as an outcome. Even recurrence is very difficult to run. And so what we did for this trial is that we actually used histologic outcomes. So based on the ATA risk classifications, how frequently was that surgery that we predicted for the patient the correct surgery. So if they had a confined tumor that had no lymph node metastases and a lobectomy was sufficient, then that was an outcome, for example. Or if you did a lobectomy that had extrathyroidal extension and you had to go back and do a completion, then clearly that it was a failure of the molecular testing to predict the right surgery. Does that make sense? So that's why we were able to get a decent power analysis with less than 100 patients. Otherwise, it would take several thousand.
Well, it's nice to know that the debate rages. It's been raging for decades, and there's a lot more data behind it and more clarity, but it's interesting to see how it continues to be all these subtle variations that, on a simpler scale, we've struggled with for decades. So I want to thank you for joining us.
Oh, thank you.
Enjoyed the presentation very much. So we'll take a few-minute break before we get into case presentations. So I write questions for CSTAPs.
Oh, yeah.
And, these various topics, came up in my group, and I said, it's so interesting how